So, for decades, ACL injuries have primarily been treated with reconstruction, but evolving surgical techniques and new biologic augmentation, we are seeing a resurgence in interest in ACL repair, and today that's what we were going to explore. Our agenda today is structured around the central question: is ACL repair finally a successful, viable alternative to reconstruction? We will begin with a brief review of ACL tears, discuss the fundamental differences between repair and reconstruction, critically evaluate the current outcomes in our traditional ACL reconstructions, and finally present the latest data on whether ACL repair is truly working. ACL tears remain one of the most common knee injuries in sports, particularly affecting adolescents and young athletes. Alarmingly, the incidence has substantially increased in the past couple decades. It's crucial to recognize that the demographic trends: females are 4 to 6 times more likely to sustain an ACL injury compared to males. If you look at the graph from the Norwegian National Knee Ligament Registry, you can see a clear distribution in peaks in the younger, athletically active population, about 15 to 24 years old, for both men and women, but again, females 4 to 6 times more likely. To consider ACL repair, we must first categorize a tear. Sherman and colleagues classified the ACL tear back in 1991. The classification remains critical for determining what patients' candidacy for repair today. Type 1 is an avulsion of the entire ligament off the femoral insertion. Type 2 and 3 are proximal tears with varying stump lengths. And type 4 is a mid-substance or distal tear, traditionally the most challenging to repair. As we'll see later, the type of tear, specifically a proximal avulsion, is the key to potential success for ACL repair. The goals of any ACL surgery, whether repair or reconstruction, are clear: is to prevent recurrent instability, restore function, allow the patient to return to their pre-injury level of activity, but we're also operating with a long-term view to preserve the long-term knee health and prevent other injuries and to mitigate the onset of osteoarthritis. We must also remember that this is a long journey, typically between 9 and 12 months recovery, with both a significant physical and mental burdens. So what's the difference? ACL repair is the attachment of the native torn ligament, where reconstruction replaces the torn ligament with a graft, such as a quad tendon, a patella tendon, or a hamstring tendon. The crucial point to remember is that repair is not a reconstruction. The two are very distinct, with different biomechanical and biological rationales. Before we dive into repair, we must ask, how are we doing with traditional ACL reconstructions? Are we truly meeting those goals? We need to critically assess the success of ACL reconstruction based on 3 metrics: return to play at the same level, the rate of graft re-rupture, and the long-term goal of preservation and prevention of knee osteoarthritis. When we look at the data, the picture is mixed. While objective outcomes are generally good to excellent at about 90%, getting athletes back to their previous competition level is less certain. Some data is as low as 45%, but there are large groups of athletes, for example, in the Moran study, which has returned to sport at 81%. Even in the professional level, the results are imperfect. Studies in the MLS, the NBA, and the NHL show high rates of return to play, from 77 to 97%. However, the NBA showed only an 86% return to play, but player performance decreased significantly when they had a 10% recurrence rate. For the high-risk 18 to 25-year-old athletic population, the estimates show that while 80 to 85% return to some level of sport, only 60 to 70 return to their pre-injury competition level. The risk of re-injury, either a graft re-tear or a contralateral tear, is concerningly high at about 15 to 25% among this young athletic group, and the time until full clearance remains typically between 8 and 12 months, with an earlier return carrying a higher risk of ACL re-tear. So the data clearly shows that ACL reconstruction, while successful, is not perfect. This leads to the obvious question: how do we improve on the outcomes? Potential avenues include refining our physical therapy, surgical technique or graft choice, exploring things such as lateral extra-articular procedures, which we had talked about previous years, perhaps even revisiting ACL repair, or a combination of all of them. So there are some compelling reasons to revisit repair now. Driven by modern techniques and our dissatisfaction with the current outcomes, repair is less invasive, uses smaller tunnels, and avoids morbidity of graft harvest, uses eliminating hamstring weakness, anterior knee pain and stiffness associated with BTB or quadriceps harvest. Furthermore, repair aims to preserve the native proprioceptive fibers, which may lead to a more natural sensation, or perhaps even more importantly, leading to less incidence of arthritis. The historic question surrounding repair has always been, can the ACL actually heal? We know healing involves 4 different phases: inflammation, repair, remodeling, and maturation. But the ACL faces a unique challenge. It's intra-articular and intrasynovial. This environment is hostile to healing. It's filled with enzymes like MMPs and plasmin, which actively break down and block the crucial fibrin clot that healing requires. But I would argue that the answer today is yes. The ligament possesses an intrinsic healing response which can be harnessed under the correct biologic and mechanical environment and the correct type of tear. The key is to either stabilize the fibrin clot with direct compression and create an environment that mimics the extracellular space, like the MCL, to combat those breakdown enzymes. So how to repair? This slide illustrates the technical approach that we used for modern ACL repair, specifically proximal avulsion. The goal is to maximize stability while minimizing the surgical footprint. We begin by clearing the femoral footprint, utilizing suture anchors placed in the femoral side. These anchors provide a robust fixation point for the torn ligament. We then pass high-strength sutures through the native ACL tissue, drawing the ligament back to the original insertion site on the femur and tensioning it. The ability to heal hinges on by overcoming the hostile environment of the interarticular environment. This is where the biologic augmentation comes in. The most discussed one today is called the BEAR, or the Bridged Enhanced ACL Repair. The BEAR implant is revolutionary because it doesn't just reattach the ligament, it creates a temporary stable environment to facilitate healing. It's bioengineered scaffold or sponge that we saturate with the patient's own blood. We then secure the scaffold to bridge the gap between the edges of the ACL and the femoral side. Evidence for the modern approaches are compelling. We look at the 2-year randomized trial data comparing the BEAR to traditional ACL reconstruction of hamstring autograft. The results show that the primary outcomes are similar. We are seeing comparable IKDC scores and similar AP laxity scores, meaning the knees are just as stable. But where the repair truly shines is the secondary outcomes. Patients undergo the BEAR represented preserved hamstring strength because we didn't harvest a graft. And they show a lower rate of contralateral tears, just 3% compared to the 7 to 10% in the literature. While the ACL remains the gold standard, we have 6 to 10 year data now that evidence is supporting that ACL repair is promising for the certain select population. There's a ton of ACL research going on at the moment. Specifically, the one that are important are the BEAR Moon trial and the ACL Restore trial, which are comparing ACL repair to ACL BTB or ACL quadriceps tendon, which are more robust grafts that we're using now. So, who is a candidate for this procedure at ONS? Our protocol as ACL repair is very patient specific. We're doing it more in adults rather than young athletes, in more of the acute setting than the subacute setting. Than the chronic setting. Anything over 60 to 90 days, probably not the best for ACL repair. Usually with Sherman type 1 or type 2 tears. Specifically, we're using a knotless all suture anchors. We use 2 of them. We use what's called suture tape augmentation, which acts as a seatbelt so that the ACL can heal and be stable while it repairs. And we're also using the BEAR implant. Here's a video of us actually doing the ACL repair. Here, you can see on the right-hand side of the screen is the lateral femoral condyle clearing off a spot on the wall where the ACL attaches. That's the anatomic footprint. We're creating an environment that we then can use these suture anchors, which will be placed through a separate portal, and then pull back the ACL to the native wall. So this is one of the all suture anchors that is placed. We then use specialized instrumentation, which is why these modern techniques are much better than they were historically. Historically, we did this as an open procedure with catgut versus these types of procedures. So the ACL is then sutured, pulled back to the anatomic footprint of the wall. As we can see, and then after it's secured to the wall, we then use this bare implant, which we put at the interface between the ACL and the femoral wall. Here we're drilling another tunnel to put the internal brace, that acting as that seatbelt, allowing the ACL to heal, and this takes some of the strain off of the ACL. This is the bare implant that we've broken up, put the patient's blood with that bare implant, and inject it right at the ACL interface. So here's what it looks like in some still pictures. The top left is a Sherman type 1 ACL tear where the ACL is directly off the footprint. We're then using those same anchors on the bottom left where it was reattached to the wall with the internal braces, that seatbelt to allow the ACL to heal, and then with the bare implanters, that creating an environment for that ACL to then heal to the femoral. So, rehab after ACL repair is pretty much the same as it is after an ACL reconstruction in my hands. Early recovery is the same as we want to regain range of motion as quickly as possible, improve strength and mobility to begin within 4 to 6 weeks, advanced recovery 3 to 6 months, and then return to sport more towards that 6 to 12 month range. So ACL repair take-home points. We don't burn a bridge, right? If the ACL repair fails, we still have a primary ACL reconstruction. Obviously, we've burned the bridge of that, just the time that it takes for all this to happen. It's much less invasive. It avoids the graft comorbidities, which then possibly a little earlier return to activities. And we definitely have an improved earlier rehab. We preserve the proprioceptive nerve fibers, and repair is emerging as evidence supported. It's not yet the standard, but it's moving in that direction. And biology is definitely, augmentation is definitely going to play a key role in ACL repair.